All right, I think we are ready to go ahead and get started. And I am very excited to welcome everyone to today's special seminar. We have visiting a world expert in photodynamic therapy and a very good friend. It's really lovely to have Dr. Vanderlei Bagnato here visiting us. He is now a professor in biomedical engineering at Texas A&M University and is on leave from his position as a professor of physics at the University of São Paulo. We actually got our PhDs in the same lab at MIT just a couple of years apart. And we did our work in very different areas as graduate students, and we did our work just one floor away from each other. And I don't think we ever met at MIT. So it has been a wonderful coincidence to reconnect. Dr. Bagnato has done some really important work in photodynamic therapy that has helped so many cancer patients in Brazil and globally. And he has won so many awards. He has over 600 peer-reviewed articles. He has mentored over 130 master's and doctoral students and done also really beautiful work to develop science education kits for K through 12 students that were distributed all over Brazil. He is a member of the United States National Academy of Sciences, the Brazilian Academy of Sciences, and the elite Vatican Academy of Sciences. But I think what is particularly impressive is how deeply he cares about helping patients through his work and helping advance students in their careers. So please join me in welcoming Vanderlei.
Thank you. Thank you very much, Rebecca. I just got out of a flu, so I am a little bit aphonic. But as I go, it gets better. So thank you very much. Actually, we did not overlap at MIT, but I was a very good friend of Mike Felt group. I have very good friends there. So I was in one floor up in atomic physics, the group of Bose condensation and all that. And this is what I'm doing even today in Brazil. I had another good friend at MIT that's here at Rice, Randy Hewlett. We overlapped, and I'm still collaborating with Randy Hewlett. So, and Rebecca said, well, we have something in common, you know, because you can do very good science. A good science is a science that advances knowledge. We all do good science, because if you're doing things that does not learn things new, but you can do excellent science. And the excellent science is the science that really open new doors. But you can do a relevant science. The relevant science is the science that solves problems of society. And I know that Rebecca is in that category, and I'm following your steps, trying to do science that's relevant, which means apply what you know to solve a real problem. That doesn't mean that the others are not important. We feed a lot of journals, right? But sometimes you have to solve problems. And some of the things I'm going to show to you, it's not, some of the things are not new, but you have to transform science in application. Really, doing photodynamic, the principle is like 2 minutes conversation. But really treat a cancer. And treat a cancer with 97% guarantee that you're not coming back is another reality. And you need to do a lot of things on there. So I'm going to tell you a little bit in these 45 minutes, I think it's 45, right? On the things we do. And I have to make sure I know how to make this go. It doesn't go. Something is not ready here. Oh, and now I have a big group in Brazil. I have a center, and I have about 28 labs. I'm not alone. We are 8 faculties now. about 120 people, and you see people very well behaved, and then suddenly you see people on the top of a car. That's a difference between atomic physics and biophotonics. And we have some laboratories inside the cancer hospital in Jaú, which is a reference, now also in the INCA, which is the National Institute of Cancer in Brazil. So basically, I'm not going to speak about atomic physics to you, but I would love to, because what I do actually is atomic physics and molecular physics inside cells. This is basically what we do, but it's not the way I'm going to present to you. We use photodynamics, which is a concept that's been around for many times. And we use photodynamics for the therapy, especially cancer, not only skin, but skin in places like Brazil and United States is a big challenge. But also microbiological control. You can use the photodynamic also for diagnostic. And more recently, we start to be pushed, especially in Brazil, to do photodynamic to clean up fungus in grains. You know, Brazil produces 25% of the grains consumed in the world. And the fungus you can kill when you boil, but the toxins left by the fungus you cannot. And then there are new diseases appearing in countries that we never knew that will be because of those toxins that goes to liver, goes to things. So we are doing that too. So the challenges that we take in my lab is microbiological control. You know, those are the words of the president of the National Academy of Science. She, together with others, predicted that we'll be expanding 3.8% of the whole world, the global economy, in fighting infections. The pandemic wasn't there at that time. And then we realized that only one bug made a big mess, but that's not the worst. The worst is the one that are turning to resistant to antibiotic, and you cannot do anything. Cancer, you know, we can do anything we want. We never knew how to treat cancer so well. The thing is, it's not available for people. If you take the relative population that today has available treatment, it's decreasing. We're producing technology that is economically forbidden for many parts of the world. We are talking about the world, not the United States, but even the United States, problems start. You cannot afford treating everybody. There are people dying of skin cancer because they avoid going to the doctors, too expensive. And pain-related chronic diseases. I have a whole group treating consequences of Parkinson, fibromyalgia, and arthrosis. But that's something that I'm not going to speak in this talk. What I use is photodynamics and some other things. Photodynamic is this process that the hard part is choosing a molecule that you are able to excite by light, and there is a nice cross-section of energy transfer to oxygen, and then you produce reactive oxygen species. Reactive oxygen species are very reactive, more than 100 kilocalories per mole, more than gasoline. They burn, they oxidize anything that is around. So it's a good technique to destroy. So what you want to destroy? Infection and cancer. Because you cannot turn a cancer cell to be a normal cell. We don't know how to do that. But I work a lot with ultraviolet and with techniques to use light to control metabolism. Today, we can do wonderful things. My mostly recent research project is putting cell in a out-of-phase situation to sleep. You know, I keep trying to make the cell think that this has a big stress of food, and then she goes to a dormance. She gets in a stage of minimum metabolic. Because sometimes if you cannot kill, it's better to let be quiet. And this I'm working. I'm not there yet, but I hope to be in the coming future. I also using ultrasound. You may not know, but there is a whole chemistry of ultrasound going on, It's called sonochemistry. Because of cavitation, big density waves, big density regions, high pressure, you make reactions to gold that normally they don't happen. So you can kill tumors by producing sonochemistry. And when you can do equivalent to photodynamics, we call sonodynamics. And now I have another project, and I even gonna offer to Rebecca because it's shock waves. With shock waves, which is different from ultrasound. It's much powerful stuff. We can go deep in, and it's not expensive. It's much cheaper than laser. So we are in this phase that maybe with shock waves, we can do a lot of things for breast cancer, things that goes beyond the surface, okay? Okay, I do a lot of science. You cannot really propose treatment without knowing what's going on. We are not transparent. I use light. Light has to interact with the volumetric part of the tissue. It's not superficial. I have to understand well how light diffuses, how light propagates in turbid medium. This is something that physicists knows how to do, and we do quite well. So by measuring whatever is coming out, we can map what's going inside that we don't see. Because as you're going to see, we have minimal invasive techniques. But you have to learn about transport. I spend part of my time trying to understand how a big molecule can pass through a membrane, how they can go to the bloodstream and not get stuck in the walls of the veins, all that kind of thing you have to do. And we have groups of people doing that. And I know we have a biostatistic here. I do a lot of statistical distribution because the cells are different. So it's not only light problem. The amount of oxygen inside each cell is different. The uptake of drug is different. There are things that we can even predict depending on the size of the cell. But there are intrinsic problems with each cell. And then I normally try to get the distribution because I know I have to cover all cells. If I don't kill the whole tumor, I'm not, hey, Jose. It's another friend from Rice University, physicist. But yeah, for you not to think that I don't like equation, I do a lot of rate equation and things, because you see, we are complex. There is a difference between something that's complex and something that's complicated. We are complex. Cells are complex. Cancer is even more. So what do? We reduce the problem to the main parameters that we can deal with because we have to predict. We have to propose models that we know that works for majority of things. So I do a lot of that. And I have a lot of laboratories that, the most thing that we do is mice, you can see. Maybe you never saw this surgery of mice in series, right? Because you needed to explore that a lot to be able to go to bigger animals and stuff. So the first thing I want to show is my story about skin cancer. I don't know how to remove that bar on the top. Do you know, Michelle?
No, I don't.
Okay, so we're gonna have to live with that. So skin cancer is not deadly, but it's very costly. In Brazil, it's 260,000 new cases a year. In the United States, it's over 350 new cases a year. No melanoma. Normally you do surgery. But you start to have complications. The cost. Diabetic people, we are living more. There is a high population of people above 60 that has cancer and has diabetes. And doing surgery sometimes is tricky. So being able to do the treatment with photodynamic is good. So this is, we do topical, you can do systemic molecules, but normally for skin cancer, up to 5 millimeters, we already learned how to do topically. And we have a device, so you put the cream, you wait. In the principle, you have to wait 2 hours of incubation. Now we are down to 30 minutes. 30 minutes, you go, you cannot even have a coffee. Your lesion is ready to be treated. And recently we developed, I have to stay here. Sorry. recently we developed microneedles. We didn't invent microneedles with biopolymers that are soluble. So we put drugs, photosensitizer, which is this molecule that I'm going to activate by light, in the microneedle so we can go deep in fast. And now we learned that even the microneedle is a good wave light guide. So we're putting everything together very soon. Treating a small lesion of skin cancer will be like making the nail. It's going to take less than 40 minutes without pain, very fast. So we have done a lot of clinical trials in Brazil, and you know, used to be 83% efficiency this treatment. We now are 95, with the target of being 97. 97 is more or less the best you can get in a good center like MD Anderson. A good surgeon can reach about 97% efficiency. 3% will have a recurrence. So it is a good thing to do. And we are now is already approved in Brazil, so in the private medicine. And now we got the approval for the social medicine. Oh, the device is very simple. This is a fluorescence guide treatment. The doctor knows that the lesion is prepared for the treatment. The same device, this device is approved already in 8 countries. And I'm going to bring to the United States now because PDT was invented here. I don't know if you know. But you don't use it very often. But somebody told me, some serious people, that even here now is becoming a problem because of facility. It's fast, less invasive, decreasing the problems after surgery. And then maybe it will be a nice, and MD Anderson is one of my partners in this separate program that we're going to bring this here. But now, and the device is simple. You know, this is a device that costs $3,000. A surgery, a very simple surgery for skin cancer here can cost that. One. This is a treatment that costs about $150. Of course, when you bring to the United States, it will cost $1,000, but that's because of many things you pay on this whole thing. And then we have to convince the insurance. But there are some people with me that said will not be so problematic to convince them because they're going to make more money. So why they not want? They may want this as a possibility. We are in many places in Brazil. I have a 70, is a large multi-center study. And this is financed for the National Bank of Brazil of Development. And INCA, which is consider the MD Anderson in Brazil for cancer, is with us. And after being with this, if you go to their homepage, they say, we changed the reality of treating cancer, skin and pre-cancer lesions, keratosis, cheilitis, and things like this. And the success is very good. And well, I'm going to jump this because this is with ultrasound for melanoma. It's my project here in the United States. But now we are approved by the social medicine in Brazil. So this treatment will be available for everybody free. And I think they're going to start at 2,000 places doing photodynamic for small lesions. Because you see, any cancer starts small. We know no cancer that starts this big. But skin cancer that starts small, they grow because people are afraid to go. You know, sometimes they think it's nothing. If it is simple, they will be more encouraged to go. Surgery is something that scares a few people, especially cancer. When you say the word cancer, they get scared. But if you promote this as simple, efficient, and if it is recurrence, you do again. It's like, you know, it's ambulatorial. You're not going to stay in the hospital. Chances of complications, you know, we treat more than 9,000 cases. Complications, we had one complications of a reaction, strange reaction, but the rest of it, very good. So this is approved in Brazil, approved last month. And they have 6 months to make available to everybody. So, and I'm supposed to build the platform of training the doctors, which we had already by the partners we had. So it'll be easy, right? And of course, we have to publish, not because we needed to make our curriculum fat, but you have to expose your ideas to the community so they can give you feedback. And I have a lot of feedback from the papers we publish. And equivalent to the skin cancer, now we are evolving to the cervical lesions. Cervical lesions, sometimes they are in situ carcinoma, but sometimes they are just virus lesion, HPV, that will evolve. And I'm very happy I'm involved with Rebecca in this global health program she has at Rice and MD Anderson. And hopefully we can go beyond the diagnostic in countries that need, we can diagnose, because, you know, having good diagnosis is wonderful. It's the first thing. But after that, well, you need to do something. And this may be an alternative for many cervical lesions in different degrees. And I have done many studies. You know, this is a CIN, is a CIN, is the stage of the lesion. One, normally medicine doesn't do anything. There is a chance that will disappear and a chance that will turn into degree 2. And the doctor follow. But we have a problem. In some countries, people do not return. If you do the treatment, we were able to increase it from 21% of no evolution to 75. And this is a simple treatment. It's a cream that the lady puts inside, and then the doctor do the treatment. You know, the device is already approved. And we are bringing it to the United States now for still experiment. And then you do the treatment, takes about 15 minutes, painless. And for the CIN 2 and 3, you know, we have above a 7% elimination of the lesions. If that doesn't work, okay, you go and do the surgery, of course. But in 70% of the people we treat, we can have a good treatment. And we evolved this device, and there is a patent in the United States, and now there is a big company that I forgot the name, are interested. We are trying to make sure that we can still make available for many things, because, you know, sometimes when you have a technology on the hands of the companies, they turn into very expensive. This is one of the things we have to worry about. We are now doing the HPV lesion. We do a lot of HPV lesion, including the oral HPV. You know that is estimated in the United States more than 10 million people with oral HPV. Sometimes does not manifest, but sometimes does. And the increase of young people with oral cancer is increasing. And we need to treat that lesion. And this is a good possibility. And comparing with traditional using the acid and things, PDT is resulting in a very nice. And then, of course, we're doing many other works in oral cavities. I like these things because normally oral cavity is very mutilatory surgery. You cannot remove a little bit. You have to. It's a radical surgery, and it's working well. And then young people and others, cheilitis. In Brazil, we have a lot of coast, and people get cancer, cheilitis, which is a pre-cancer lesion on the lips, and this is doing well too. You know, a very good result is going on. And then we have a larynx program. And this is how I am in cancer. We do esophagus and bladder, but this is like a small group. And because it still seems that they have good procedures with surgery, we didn't reach the level what surgery is still better for those cases. Now I want to change a little bit, speak about resistant to antibiotic bacteria, because you know the conventional bacteria that produce diseases. My focus is pneumonia, but there are a lot of bacteria that are resistant to antibiotic. They are becoming resistant. How a bacteria became resistant? Well, somehow the bacteria change and make sure that the antibiotics not be effective. And the most important one is production of some enzymes that destroy the molecules of antibiotics. But also you have the efflux pumps. That molecule they get in, they eject. So there is no effect in there. Membrane are modified and became reflective to those molecules. And then there are many other ones that are that happens and make the most important mechanism of resistance are the ones that I told you: the flux, the membrane, the enzymes, and modified target. The cell modify the target of the antibiotic, so the antibiotics gets there and have nothing to do. It turns out that all those things we can affect with photodynamic. So what I'm going to show to you is doing a sublethal, a subdose, very tiny photodynamic. We destroy the mechanism and the bacteria became again, because we can kill bacteria with PDT. But suppose pneumonia is inside your lungs. The best I can do is a tiny shock. I can make light get to the lungs. I can make a drug goes to the lungs by breathing, but I cannot eliminate all, but I can make them back to be susceptible to antibiotics. So that was the program. As you know, the resistance of a bacteria is measured by this MIC, minimal inhibitory concentration. You know, of course, if you give a kilo of antibiotic to a person, you're going to kill the infection and the person together. You cannot administrate any dose of antibiotic. There is a minimum or a maximum you can do it. And there is a minimum they respond. Normally, you have a curve of the MIC versus concentration. And whatever you inhibit the growing is where you inhibit the bacteria. That's the dose, minimum dose you have to work. That's the MIC. Whatever the bacteria is turning resistant, this curve is moving to the right. And we have to push back to the left. Some time ago, we published a paper and we saw that when combining antibiotic with photodynamic, we discovered that, well, the antibiotic is acting better. So we must be facilitating the antibiotic action. It's not only addition of effects, that is a synergic effect. Okay. Well, then we did a little more serious work, and we could measure that by doing a tiny exposition of the bacteria to photodynamic, we decreased the MIC. This was published in 2019. But then, well, I thought I had a good things on hand. Last week, we published another paper, and there was one a little previous, where we demonstrated that by doing a little sequence of shocks, we can bring the infection to be below originally what was. So you see the MIC, as you can see, I don't know if you can read the numbers, sorry, that's small numbers. Sometimes you need 1,000 micrograms per milliliter to kill bacteria. This is an in vitro experiment. So bacteria are so resistant that if you want to treat the whole body, you're going to have to put many grams of antibiotic. This is not feasible. But by doing tiny shocks, you don't kill the bacteria because it's subdose, sublethal. To kill a bacteria is like kill a cell. You need to give a threshold dose. If you do a tiny little damage, you don't kill. But it's enough to destroy those main mechanisms that will turn into bacterial resistance. So we can bring down, here we work with bacteria, the MRCA, which is the methicillin resistant, which is the most common, but we produce bacteria that are resistant to amoxicillin, erythromycin, gentamicin, which are the most common antibiotics. And you can see that we bring down. So we make them viable again for antibiotics. So then you can guess what's the idea. The idea is you have an infection, you go with both, with the antibiotics and the photodynamic when you can. Some infections are systemic and we don't know how to deal with that yet. And then is the bacteria returning to be resistant after that? Yes, after a few generations, it seems the bacteria recover but doesn't matter. You need to cure infection. So that infection, if you break down the resistance of the bacteria, you are able to turn into you turn the antibiotic effective again. Because we cannot throw away the antibiotics. That's the good thing we have in medicine. So and they declare that we're not going to have a new generation of antibiotics that will solve this in the next 10 years. So what are we going to do? People are dying in the intensive care of pneumonia every day. And in the COVID, people die more of pneumonia than anything else, right? Because they are intubated and everything. So it's complicated. So knowing this, we develop a way to clean it up the mouth. Why clean it up the mouth? Because in many cases, you want the mouth is the main mechanism of infection. So in some cases, clean the patient. You avoid the infection during many procedures. And it works well. But then came this other idea. The young kid, pharyngotonsillitis, infection on the throat. That's one of the most consumption of antibiotics in pediatric. And if you have a kid, you know that many cases, the antibiotic did not work, the first one. You have to come with the second and sometimes the third because they are resistant to those antibiotics. Do you know how many classes of antibiotic we have? Alternative A, 1. Alternative B, 10. Alternative C, 100. Alternative D, 1,000. Make a choice.
100.
No, we have less than 10 classes of antibiotic. Principles. Then we have different configuration, but it's not too much. If they turn into, that's why it's a big problem. Because bacteria are turning resistant very fast to those. And we don't know, we cannot create more classes of antibiotic. Not fast enough that we need. So, pharyngotonsillitis, that's a problem. And it's turning to resistant. You can get kids that do not respond. Infection that doesn't work. So here, what we did in Brazil, after this whole thing, we give a Laripop or, I forgot the name of this pastille. Like what this is Laripop. What about this one? A candy or syrup. So you give in 5 minutes this go and gets into the infection. And then we do the treatment. And of course, this is also fluorescence guided because having devices that you can see fluorescence is very good for the doctor because he can see sometimes the infection goes much beyond the inflammation. And then they can see. And the result was fantastic. In the 94% of the kids we treated get free of infection in 12 hours. The antibiotic is 48. And in adults, we have a lot of adults with chronic infection. I may be a candidate because, 92. We're going to improve that. But the result was fantastic. The kids love that. There's no pain, nothing. And you give a Laripop. What else? Have you ever gone to the doctor that give you a Laripop? The kid wants to come back to the doctor. And this works very well. It's now approved in Brazil for a big clinical trial. And this is one of the things I want to convince Rebecca that we should do, because in countries that we are interested, infection of the throat is very common. And sometimes they don't know what to do. We went to Mozambique together. I asked the people, how available are antibiotics? Sometimes they are not so much available. And this can be a good thing to do there. But you cannot stop there. We have many pathways of infection. One of them is intubation, mechanical ventilation. When you prepare the patient with intubation, you already give antibiotic because infection will come. And what we did is the same principle. I functionalize the surface of the tube. And then together with the tube goes a fiber that illuminates the tube from in and out. And guess what's happened? You know how the infection works there, right? You start to form colonies. The tube is a strange object. There is no bodily circulation. Doesn't matter if you give antibiotic, you're going to prevent the infection when it gets out of the tube. But the colonies of microorganisms that gets in the tube is the problem. So you have to prevent that, because they're going to just come down to the lungs. So when we do that, we stop the progression of the infection. We are in pigs now. We're doing pigs, and it's getting very well, because we see that doing that, in some cases, we zero the infection. But what is important is whatever is the level of infection naturally was there, that doesn't progress. And if you don't do anything, that grows. And if you can see, after 3-4 days of intubation is when the problem really starts. Doctors know that. Sometimes they change the tube, but that's not easy. The patient is there on the intensive care, sleeping probably, and you have to do this whole thing. But if you can do that, can we treat the pneumonia? Let's imagine the picture where we inhalate a molecule that can go to the lungs and find the infection and get to the colonies of bacteria. And we wait a little bit, and then we do an extra body illumination. You're going to say, we are not transparent. Yeah, we are not transparent to visible light, but to infrared, I can make infrared go that deep in you. Sometimes you put a source of infrared here, you can see some light coming on the back. So if we get a drug that's in the infrared, and we can make it get there, we can do it. We can treat pneumonia, especially the resistance to antibiotic, because if the antibiotic solves the problem, let's continue. In rats, works perfect. We instillate, rats do not develop pneumonia every day, right? You have to provoke. And when we do that, you can see that the ones we treat, we eliminate. The ones we don't treat, they start to die, following the Kleppner diagram type. And but the rats is not our target, right? We need to go to big animals. Oh, then we do also. You have to know if the mucosa is being affected, what you're doing, and then we did a lot of work on this. And you don't have to worry, because this is very protective. But we need to go to humans. But we don't know exactly to go to humans, so let's go to pigs. And then we go to pigs. Well, we did everything. We can eliminate a lot of you see, the chamber of the pig, when you illuminate with infrared, is like a big lamp. Infrared goes through very well. And those are 60 kilos pig, it's like us, big thorax. And those are experiments with pigs. And there are models of pneumonia in pigs. We do the treatment. Look, I need to decrease 6 logs of infection. Otherwise, nobody pay attention. Here it doesn't go even a log. What's the problem? The problem is inside our lungs, we have one thing that's called surfactant. Is a kind of detergent that traps things and traps my molecules. The rats has so little surfactant that doesn't matter. But the pig and the human, they do. I have to solve that problem. We did all kinds of work. Molecular dynamics simulations, lung blood studies. Oh, there comes an idea. Do you know the substance perfluorobromate? This is a substance. It's a liquid that percolates gas. You can swim and breathe. You know, it will be very impressive to make a swimming pool of perfluorobromate. You can swim and breathe. That's very nice. So let's do fluorobromate. We did the fluorobromate. Oh, improves a little bit, but not now. We are 2 orders. But imagine a patient, intensive care. I'm gonna fill it up his lungs with perfluorobromate. Forget it. No doctor is going to do that. Too risk. We have to solve it from another way. Here's the solution. We find a biopolymer that is commercial. They put even in food, fully non-toxic. And we can put the drug inside. This biopolymer dissolves very slowly. It moves around the surfactant and gets to the colonies of infection. And then start to dissolve and deliver there the drug. And we succeed very well. And we are very happy. And now we are getting approval, and this I'm starting to do in College Station and in Brazil for the pigs again. If we pass the pigs, we may evolve to humans, right? Because it is a big demand. You know, if you see the amount of people dying is a lot. But we have also to learn how to identify resistance to antibiotic bacteria. Today, you get bacteria, you get infection, you have to put antibiotics to see the response. It takes a few days and it's very costly. And then you die because sometimes you cannot wait. You cannot wait hours to take action. I know that very little can be done if you go more antibiotic, more combinations, more everything. But this is a very nice paper that's coming out, is accepted, that using machine learning. You know, machine learning is everywhere today. Even when you're going to a coffee shop, they're going to start to use artificial intelligence to look to you and say, oh, you like vanilla. And then by doing Fourier transform spectroscopy of different groups of molecules in the microorganism, so you make a swap, you collect, put in the spectrometer, and let the machine to go. And then we do the principal component analysis. Look, we can find exactly if the bacteria is resistant, and more than that, is resistance to what classes of antibiotic. So we hope this will be good too. And well, I'm passing fast here. And then we did a blind test. People gave us bacteria resistant to some antibiotic, and we test. And in all the cases, we were able to find out if this is good. Finally, I'm also involved in some cleaning up of organ for transplantation. If nothing works, you may have to have a lung transplantation or liver or kidney. Donors are each time more. I don't know if you know the cost of a transplantation today is huge because there is no organ available. But there are a lot of people dying of some diseases that we can clean it out. Hepatitis, many other things we can clean it out. And we demonstrate, these are in those papers. We're doing lungs already, humans in Toronto. And in Brazil, we're starting to do liver and kidney cleaning up, circulation, photodynamic, UV on the liquid that circulate, and we'll be able to decrease almost to zero the infectants. And I know this is a place that more is about translational research. So I'm worried too. I help to start many companies with many devices, all in medical business. And I hope we can do here too some work. And my job with Rebecca, she told me, well, you have to push some translation. And I took seriously the assignment. Look, I have a group of people in Brazil. This This work was mostly done in Brazil, but I have collaborator in College Station, Toronto, and in Portugal. Those are people involved in my publications. And so we have some challenges to do. We have to find more smart molecules, but there are a lot of good molecules for photosensitizer. The thing is, you have to find smart ways to delivery. Everybody goes to nanotechnology, but sometimes there are better and less expensive way, because nano objects in your body, we don't know exactly, we don't have a clearance for using nano objects in our body as we want. But the substance that people use in food is much easier to approve. And believe me, there are more in those substances to go through, to find targets than we think. And then, well, this is some of the things we're doing. We have a few other projects, the dormants of cells. I think this is significant. Pediatric cancer. Pediatric cancer is something that touches everybody. Technology is not evolving, even though medicine is evolving quite well. But the technology by itself, you know, instrumentation and everything, I don't think it is. So that's a target. And I have also a program of cirrhosis. It's very nice that in animal model, we can kill the cirrhosis part of the liver without killing the normal cells. And there is a chance that after you kill, liver regenerates very fast. So my hope is that decreasing the cirrhotic area, maybe you give another chance for the people, because the number of people dying with cirrhosis is also very big. If it is not, don't think that people are drinking more. We are taking more medications. We are living more. We are surviving a lot because we have good drugs, but they are not so friendly to liver most of the time. And we know that some of the problems, glaucoma, if you take some medication for glaucoma, people knows affects your liver and affects some other things. And believe me, this is already starting to work in mice. And I need to get good partners on this here in the United States. And why I came to the United States? Well, because I was graduated here. I never returned to live here. I'm trying to end my life around here. So that's why I'm in College Station. And I hope to be closer to Rebecca. Believe me, many of the programs here is very much admired, right? And I think I want to be part of this. And we are already doing things. It would be nice to collaborate here and with MD Anderson in the melanoma. My job in here is melanoma. And believe me, we are doing very well with sonodynamics. We can, melanoma is not as the basocellular or squamous cell, but you have a decent amount of million people with melanoma. And there is good solutions, but not enough. Survival is still a problem. Maybe extra technology increase another 20% survival will make many people happy. Thank you very much. If you have any question.
Thank you so much for sharing all of your experiences. With photodynamics, I guess we need a little.
Sorry, we have people online, and so we want to make sure everybody can hear.
Awesome. Again, thank you so much. Amazing talk. So with photodynamics, one thing I'm curious about understanding is how are you able to target, for example, for antimicrobial properties, you mentioned there's like 4 different things that the bacteria is doing to become more resistant, whether it's developing a different cell wall or changing the target of the cell. How does photodynamics affect the bacteria? Is it opening up pores in the cell wall that allow it to then have the antimicrobial properties, or for example, the antibiotics be able to go in and actually fight off the infection?
Okay.
How does it work?
Is the following. You have a gram negative and gram positive The gram-negative, we are still fighting. It's very hard to make a molecules to get in, but there are many different ways. The gram-positive is easy. It eats those photosensitizer, like eating food. Once those molecules are inside, the tiny oxidation seems to destroy the easiest targets. And the easiest targets are production of enzymes, membrane, resist everything. So luckily, the photooxidation reaches very well the targets that turn the bacteria resistance to antibiotic. Now, why? Because probably porphyrin, chlorine, this whole thing looks like food for bacteria. You know, indocyanine, they eat like crazy. If you take a colony and you put this, in a few minutes, the uptaking is huge. So we are using this characteristic. But now, there are big molecules that do not get in. We're not working with them. You have to search for the best molecules. But if we prove the principle, I can guarantee to you that 1,000 chemists will produce photosensitizer specific for bacteria. They're already doing this.
Thank you. And just to extrapolate that, how does that work then for cancer properties? How is it that the cancer cells, for example, are taking up the photophores, but then
Well, the whole dynamic of uptaking of drug, the cancer cells, so fragile. If you can damage the membrane, you know, those low density lipoproteins that makes the membrane is very not so well organized in a cancer cell. Molecules can, and then anything you oxidize in the cancer, the threshold of damage in a cancer cell is small. If you make the drug to go in the right place, you have a good chance to destroy. That's why I believe photodynamic is very good for that. And why is not the United States a main choice? I think it was the wrong choice at the beginning. One company makes drug, the other make equipment. And when you have the equipment, you don't have the drug. When you have drug, you don't have equipment. Never there was a matching, a good marriage of all the things. And if it was, there are many things you can treat with photodynamic. In some places in the United States, they're still treating esophagus. Okay.
Thank you.
Any question? What I do in atomic physics? I do Bose-Einstein condensation.
Thank you for the talk. So my question is about other types of cancer, for example, like leukemia. Is it possible to be treated in the same way?
Well, we believe because you see, during the COVID, and there are people that claims that we can decrease the systemic quantity of virus by doing systemic treatment. But if you see the data, you know, it's not something to tell your mother about yet. We need to go more deep in this leukemia and things like this. But maybe it's possible, but it's not well available and not there yet. But in the principle, if you can target the right cells and the right spot, you should be able to improve. But I know very little people doing that. They do. You see, you have to start in the lab. Anything you do, start in vitro. I know it's not the automatic translation to animal model and to clinics, but if you don't do in vitro, you don't get acquainted with all the required ingredients, right? And then it's easier to add complications. And then this is what you have to do. We have to start leukemia in a different mode. But breast cancer with sonodynamic, because with ultrasound, you can even focus what you want inside the body. People learn how to do that. I think sonodynamics will help a lot. Breast cancer and other types of cancer that are deep in. People go with fiber, but that's not so comfortable for many people. If we can do fully external, will be possible.
Thanks for the talk. So you yourself are talking about targeted, sort of the infusion of targeted therapies that then can be activated with the photodynamic therapy. And so I'm curious, like it does start in the lab. I'm wondering if there are targeted molecules that can then that you guys are kind of investigating. HPV would be perfect for that, right? Because then there's so many HPV targets.
HPV works well with porphyrin produced, the cells, because when you have that lesion, what you have is a big colony with self-producing virus. That's the machinery of virus production. All those creams based on ALA and MALA, they are wonderful. You put even sublesions. You have HPV that did not came up yet. But you put the cream, wait a little bit, and you look fluorescence. That spot produce so much porphyrin that you can target. So for HPV, I think we have to use well that solution. Now, it may be there is a big community producing photosensitizer. I am in that group of people that believe that we have to make good use of what we have and then explore. Because if every time you open the journals, a new photosensitizer. And then I go to see, it's just a new, it's not more efficient or with some specific properties.
Yeah, that's what I'm thinking about in terms of specific properties. So I'm thinking about other virally mediated cancers, for example. So EBV related cancers like Burkitt's lymphoma, some of those lymphomas and Kaposi sarcoma.
Yeah.
So if you could find targets that are targeted
Right.
to Galana antigens or antibodies that drive those cancers, is that something that?
Yeah, that's something good. If you can bind the right photosensitizer in the right place. During the COVID, people are decontaminating the nose and the mouth, everything with curcumin. I also like curcumin. Curcumin is wonderful. You put in food. Everything you eat, I like. Because I know that's not going to have a collateral effect, side effects, right? And curcumin is a wonderful photosensitizer. Nothing of curcumin, but has to be the right curcuminoid. If you put in the food, you get that yellow, but it's already a different thing. Yeah, curcumin is not a very tough molecule. But they are wonderful bactericide. They can go almost in all bacteria, even the gram-negative. Okay?
Obrigada, Vanderlei. Excellent explanation and an amazing talk. Thank you. We learned so much. I'm curious, as Yaja, and I understood that the cancer cell is super disorganized and easy target. But how about the pre-cancer lesions? Because it's not so disorganized, but with damage to the tissue.
Yes.
And my second question is, how deep we are going if we target the pre-cancer lesion, for example?
Okay. Today, we can go to lesions. I have many techniques I didn't show to you. I have negative pressure. You have a lesion on the skin. I suck. You know this negative pressure? I bring all the thing. Believe me, I can go deep like almost a centimeter, but that's not what we. So I think lesions up to 4 millimeters, I can deal with today efficiently. But most of the pre-cancer lesions, cheilitis, keratosis, I'm talking about skin. This is my experience. They are not so deep, and you can do well. They are not as different from the normal cells. But, you know, selectivity you can do in different ways. Either by the uptaking, which is better for cancer, or by illumination, which in the case of, you know, we're treating keratosis on the whole arm of people, and works perfect. What you going to do with a guy who has keratosis everywhere? You're not going to remove. The doctor's not going to remove. What he's going to do is put a cream, like palliative stuff. We have a device that you put the whole arm for 30 minutes and it cleans more than 40%. That's good. Because you can do a few sections and then you reach the level that you want. I don't know. And then you have another question. How deep I go? I think I answered the second before the first. But you know, I'm doing all kinds of tricks. Combining ultrasound with photodynamic, combine negative pressure. I believe in the melanoma, if you have a melanoma and you do negative pressure, I kill all around the melanoma without touching the melanoma. This is what I'm proposing. In many cases, a crown melanoma, which is in the foot or on the hands or in mucoses, we can do negative pressure and PDT. And I believe we be killing by isolating the melanoma. This is the ideal for melanoma. Melanoma is the guy you don't want to touch a lot, right? You want to kill without the melanoma knows. So you kill everything around. Melanoma dies. No more supply of food, oxygenation, anything. We have done I show a mice model. We are doing, my project now in College Station was just approved for animal. And we are developing a pig with melanoma. You know, these simpler mini pigs, 3 to 6 kilos. That's a wonderful animal for studying melanoma. And I think we may have a good idea there.
Well, let me just say thank you so much for a really wonderful talk. Please join me in thanking Dr. Bagnato. Hopefully you can stick around if people have a few questions afterwards, but thank you so much, everyone.